Perfect. So we're going to start with hip flexion. So all the way up to the top. Anything there?
No, feels good. So
No.
what do we think it needs to lengthen there?
So we've got quads and then obviously the capsule at the top.
Yeah.
Then we've got internals.
So sorry, say that again. So quads
Yeah.
into hip flexion.
Oh no, sorry, I'm thinking knee
More-
flexion.
Yeah, more hamstrings.
Hamstrings, yeah.
Hamstrings first, then I'll think the posterior capsule.
Yeah. I'll just try that one again.
Yeah.
Nice. That
But
okay?
no, you are right in the fact that because we're bending the knee here, we are going to need some length to the quad, especially
Yeah.
the rec fem.
Yeah.
That's actually a good point because sometimes you will get a pinch sometimes in the hip where it's actually the rec fem, because even though rec fem is going to be shortened at the top, because we're bending the knee most of the time going into this position, there is quite a lot of length going through that rec fem as well. So actually in a way you're not wrong, but obviously for the hip we're more interested in the hamstrings.
And then anything there?
No, it feels good. A little bit tight, but it feels well.
And out. Anything there?
No, again, just a bit stiff.
Yeah. And then into knee flexion. So heel to bum. And then extension. Like that. Perfect. Oh, and abduction. Happy there?
Yep.
All right. A bit further?
Yeah. That's pretty range. Yeah. And what do we think it needs to lengthen there mainly?
Adductors.
Yeah.
And then adduction.
Yeah. And that's going more
So
like
they-
that bit than
yeah.
this issue up here. Not
Yeah.
perfect.
Perfect.
Cool. So yeah, so I suppose the biggest takeaways from all the passive assessment is always think of what needs to lengthen. Now this is just going to tell us maybe the adaptations that the body's adapted in response to pain. So maybe if I've had an old groin injury, let's say, maybe now my adductors are going to be a little bit tight, like there's going to be some protective tension there because of that previous groin history.
Right.
Maybe. Does
Yeah.
that make sense? And that's maybe some of the things that we're going to have to desensitize to get rid of the symptoms. So if I'm getting a pinch and deflection, we might need to treat the adductor magnus to treat that pinch and treat those symptoms.
Okay.
Then a rehab wise, we might be looking at other tissues, but for the symptoms, this passive assessment is going to give us a lot of clues and information.
Right. Perfect.
Cool, so we just recapped, we just finished week 2, so we're just going to recap and talk through really the key takeaways that Sarah has got out of it. So I suppose, what are your key thoughts on week 2, Sarah, once you finished?
I like the structure of it.
Yeah.
I definitely think that when you're at uni, you kind of like just thrown a lot of stuff to look at, whereas this, you've got like the set structure of things that you know you need to go through. It's simplified as well, it's been a lot easier.
Yeah, no, good.
Which is good.
And I suppose in module 2, so it links nicely on from module 1, which we'll talk about in a second, but I suppose the big things from module 2 is getting solid with the generic objective, solid with your passive assessment, solid with the coordinated testing, and then basically knowing where you're going from a treatment point of view from that.
Yeah.
Does that make sense?
Yeah.
So I suppose, which part of that have you found the most challenging so far?
I'd say, I don't think there's anything specifically. I think it's more a case of being able to put it all together as a whole and like effectively be able to explain it, what you found to someone, and also get clarity in your own head, but then like kind of show them as well that you know what you're talking about.
Yeah, I think that's it. Like, you hit the nail on the head there, where it's about clarity. So if you've got clarity in your own head about what's going on, which is where your subject of module 1 is so important, because that's going to give you a lot of clarity on the previous history, and then that's going to help you make sense of what you actually find in the objective assessment with module 2. And if you've got both of those things, it should give you a lot of clarity in your own head of what the problem is. If you have clarity in the problem, it's going to be a lot easier for you to explain that to the patient. And if you can explain it well to the patient in a way that they understand, it's going to be a lot easier for them to buy into the treatment plan. So it's really, really important, I think, to kind of nail that. And I suppose the key takeaways is, when we're doing our assessment, is we want to have history in the back of our mind all the time. So if I'm seeing somebody with lower limb, let's say, and in the subjective we've got a lot of history, let's say, around the ankle, and they've come in with knee problems, when I'm doing my objective assessment, I'm very interested in what's happening at the ankle.
Yeah.
And anything I find, I want to try and link it back to the history as much as possible. So that it should make sense from history about what's actually driving the current problem. So rather than focusing all my attention on the symptoms, which is the knee, maybe there's something not happening around the ankle that's causing that knee now to get overloaded. So I think that's the key point, really, is being able to link module 1 and module 2 together is really, really important. Yeah, no, perfect. I suppose the big thing now is just implementing it. So I think it's learning it's one thing, but I think until you get out there and start practicing it and dealing with real people, real clients with real objections and real issues, that's when it becomes an issue.
Like, it's alright having all the information and knowledge in your head, but it is like you said, literally being able to feel for certain things when you're doing it as well. Like when we've gone through case studies and stuff in the past, it's alright saying, oh yeah, they've got this or they've got that, but like actually being able to know that that's what it is, you know, like they've got weakness or whatever it is. It's knowing that and then being able to remember it from the assessment that you've done and applying that into being able to explain it to them.
No, definitely, yeah. I think again, like, it all leads on to the same point in that if you understand somebody's story well enough, it becomes easy to remember all the assessment findings. So you're not just trying to remember a bunch of different pieces of information that you've got off a pre-assessment questionnaire or something like that. It's you truly understand their unique story of what got them to this point. When you're doing the objective assessment, everything's going to start to make sense. So like if we're seeing like poor force transmission through the gastroc, for example, but we know there's an old ankle sprain there, it makes a lot of sense. When we see that person waiting in the corridor, I don't need to look at the notes, you don't know me to remember, but that's the guy who had that ankle sprain and now his gastroc isn't looking very well. And that's a real crude example, but when you've got someone's history and you know their story really, really well, you almost don't even look, obviously it's important to keep your notes, but you almost don't even need to look at the notes to know where you're going in the next session because you remember it. Because it's a lot easier to remember stories than it is just to remember a bunch of random information. So I suppose what we didn't spend that much time on this week really was the treatment side of things. I know we spent a little bit of time on it, but I think the treatment, and we'll spend a lot more time on that over the next couple of weeks with the other modules. I think the treatment side of things is really straightforward once you have that clarity on what the problem is and the solution. So once you can formulate the treatment plan, usually the treatment becomes pretty straightforward after that. I think the hardest thing is actually finding the true stressor in the first session and being able to formulate what the actual treatment plan is going forward.
Yeah, definitely.
How are you feeling about the treatment stuff at the moment?
I feel alright. I think I just definitely need to start practicing and getting it in my head, like I said before, like knowing what's you know, like if they've got PKS positive thing, knowing what that actually feels like, knowing that alright, okay, they've got weakness in the hamstring or where they're breaking kind of thing, and then like I said, being able to explain it like that. I just need to put it all together and be able to like deliver an effective assessment.
No, definitely.
I need to keep practicing.
Yeah. And I think that is the key skill is being able to link everything together. And there's a lot of physios out there that are like shoulder specialists, knee specialists, whatever. But I think we need to be able to link the whole assessment findings and how this person as a whole is moving, how they're living their life, their history. We need to link it all together and use that to form a hypothesis of what's driving their current pain experience, if it is pain that they're suffering from. But it's about being able to link everything together. I think is the key point. I think that's the big thing with the mentorship as well. We divided it into modules because it's a lot easier to teach, but really it's the whole system, and it's applying that system to individuals, I suppose, actually with lots of complex problems. It's trying to make the complex really, really simple. I think that's the skill, is being able to simplify some of these complex history and complex assessment findings, simplify that into an explanation that makes sense, but that's easy to understand, and then be able to drive a treatment plan from there. But I think you'll find now as we go into module 3, module 4, module 5, which is the upper limb, the lumbar spine and the cervical spine, is it gets a lot easier now to start to kind of understand everything, because the principles remain the same. It's still thinking about what's lengthening, still thinking about what needs to be able to load, linking it back to the history, just the tissues now and the things that we're looking at are going to be slightly different depending on the body part.
There was definitely a lot to look at in that module.
Yeah, and I think the lower, the lower limb as well. Once you come out of the subjective, which again, subjective, there's a lot in the subjective as well, but it's kind of all logical. It kind of all makes sense. It's fairly. It's not too deep, I suppose. Whereas then when you get into module 2 and it's your first time coming across the mentorship way of thinking, it's like a whole lot of new information. When you get into the upper limb, there's still a lot of information there, but a lot of it's not new anymore. It's just building on the same principles. And then same module 4 is building on the same principles again. And it gets easier and easier to kind of learn it as you go through. Then when you get to the later modules, like the return to play stuff, it gets a little bit different again, and then you kind of build on that as well. But no, you're doing really, really well. I think it's just getting used to doing it with people, actually implementing it, and like you said, forming a full picture of what's actually going on.
Yeah, definitely.
So next week we're going to go on to module 3. So module 3 is all about the upper limb, and it's really the first kind of 3 sessions for the upper limb. So it's going to be our objective assessment, which is going to be a generic objective, our passive assessment, and a coordinated testing mainly. And then we're going to have our treatment and our first stage rehab for the upper limb. That's all in module 3. So that's what we're going to go through next week. And then, like I said, it's just building on the same principles as the lower limb. So I think you'll find the upper limb is a little bit easier, just because you've already got the same principles from the lower limb.